All right, let's get right into it. We're going to break down one of the most powerful tools out there for personalizing mechanical ventilation, NAVA. We're going to walk through the entire process, step by step, from getting that ED catheter in place all the way to fine-tuning the therapy. So here's our game plan. We've broken this down into 4 key parts. We'll kick things off with sizing and insertion, then we'll jump over to positioning and how to verify it on screen. After that, we'll get into the nitty-gritty of NAVA startup and titration, and we'll wrap up by tackling those common clinical alarms. Think of it as a complete roadmap. Okay, part 1, sizing and insertion. Like with any procedure, getting the prep work right is everything. It's the foundation, and everything that comes next really depends on getting these first few steps just right. First up, you've got to select the right tool for the job. And this sizing guide makes it super simple. You just match your patient's weight and height to find the correct catheter size. So, for example, if you look at the chart, a patient between 1 and 2 kilos and under 55 centimeters, well, they could use either a 6 French or an 8 French catheter. Now for what is maybe the most critical measurement of them all, the NEX. And that stands for nose, ear, xiphoid. Just look at the diagram there in step 2. You're going to measure from the tip of the nose to the earlobe and then straight down to the xiphoid process. Get that number in centimeters. It's the magic number you'll need to calculate your insertion depth. Got your NEX measurement? Great. Now you can figure out your target insertion depth. This table gives you the exact formula. Just find the catheter size you picked a minute ago and plug your NEX value into the right formula, whether you're doing a nasal or an oral insertion. That's going to give you Y, your precise insertion depth. Okay, it's time to insert. Just follow these steps one by one. First, connect the ED module to the ventilator. Second, dip the catheter tip in some sterile water to activate its special coating. Third, and this is the big one, gently insert the catheter to that exact depth you just calculated. And finally, connect the ED cable to the catheter itself. And I have to pause here because this is so important. Do not, I repeat, do not use any lubricant, gel, or solvents. The catheter has this special hydrophilic coating that's only activated by sterile water. Anything else is going to mess with its function and could even damage the electrodes. It is an absolutely critical safety step. Let's move on to part 2. So the catheter's in, but now we have to be sure it's in the perfect spot. This is where we get to use the ventilator screen as our eyes to see exactly what's happening inside and confirm our placement. Getting to the right screen is a piece of cake. On the ventilator display, you're just going to tap Menu, then head over to Neural Access, and finally select ED catheter positioning. This screen is going to be your best friend for the next few minutes. Now this is where it gets really cool. Think of these ECG waveforms as your internal GPS. If you see P waves lighting up on all 4 lines, that means the catheter is too high. Just push it in 1 centimeter at a time. If you see almost no P waves and the QRS is dampened, it's too low down in the stomach, so you'll pull it out 1 centimeter at a time. And if you see big P and QRS waves on both the top and bottom, that means it's curled up. You'll need to pull it out and start over. So what does perfect look like? What's the bullseye? You're looking for all 3 of these things to be true at the same time. 1, the P waves are biggest in that top ECG lead. 2, the QRS complexes are nice and big at the top, but get smaller or dampened toward the bottom. And 3, the ED signal, that pink and blue bar showing diaphragm activity, pops up right in those 2 middle leads. Once you've hit all 3 of those targets, you are golden. The final step here is to make any last little adjustments, secure that catheter so it doesn't move, and this is really important, document that final insertion depth in the patient's chart. All right, on to part 3, NAVA startup. The catheter is placed perfectly, which means we can finally start using it to deliver that Neurally Adjusted Ventilatory Assist. This is where the magic happens. When you first kick off NAVA, you'll want to use these settings as a solid, safe baseline. Your NAVA level, which is basically the amplifier for the patient's effort, should start low, around 1.0. Set your PEEP to whatever it was before, and an apnea time of about 2 seconds is a good starting point. This just gives you a secure place to start from before you begin fine-tuning. Now, this is an absolutely critical point about the peak pressure alarm. You need to set it high enough to give the patient room for spontaneous sigh breaths, which are a totally natural, healthy part of breathing. The machine will limit the actual peak pressure to 5 centimeters of water below whatever you set this alarm to, so giving that extra headroom prevents a ton of nuisance alarms. NAVA is not a set-it-and-forget-it mode.
It's a dynamic process, all about titration. Your goal is to keep the patient's work of breathing, which is represented by the ED peak, in that sweet spot, that optimal range of 5 to 15. If it's too high, the patient's working too hard. You need to increase the NAVA level. If it's too low, they might be over-supported, so you'll want to decrease the NAVA level.
And that brings us to our final section, Part 4, Troubleshooting Alarms. Really understanding what these common alerts are telling you is the key to managing your patient effectively on NAVA. You're going to see the pressure limit exceeded alarm pretty often, and usually it's no big deal. It often just means that peak alarm was set a little too low, like we just talked about, or maybe the patient just gave a big cough or a sigh. Your first move is simple. Just increase that alarm limit and watch the patient.
Okay, but what if you see the patient retracting, or you notice a consistently high iliac peak? That's a huge clue. It's telling you they are under-supported. They're working way too hard. Your game plan is to first increase the NAVA level. If that doesn't fix it, recheck your catheter position. You can also consider increasing the backup pressure control setting.
Now on the flip side, what if the ventilator is spending a huge percentage of time in backup mode? Well, that usually means the exact opposite problem. The patient is over-supported. Their own breathing drive is being suppressed. The fix? Decrease the NAVA level. You can also try decreasing the apnea time a bit or adjusting your backup settings. This last one can be a little tricky. The patient's oxygen requirement is going up, but their eddy signal, their own effort, is low. That's a disconnect. It could mean they're over-supported or maybe over-sedated, or it could mean the catheter has slipped. The key is to look at the whole picture. Try decreasing the NAVA level, assess their sedation, and, if you need to, re-verify that catheter positioning. So, to wrap it all up, let's boil it down to the key takeaways. First, that accurate NEX measurement is the foundation for everything that follows. Second, always use the on-screen ECG and ED signals to be sure about your placement. Third, remember to constantly titrate your settings to keep that ED signal in the optimal zone. And finally, learn to tell the difference between an alarm that signals a real patient need and one that's just a settings issue. Ultimately, it all comes back to this one thing. Your entire goal is to use this amazing technology to read the patient's own neural respiratory drive, that ED signal, and give them support that is perfectly in sync and perfectly proportional to what they need. You're matching the machine to the patient, not forcing the patient to match the machine. And that really just leaves us with a final thought. This isn't just about learning how to use a device. It's about reaching a whole new level of patient care. So the real question to think about is, how can mastering this kind of patient-ventilator synchrony truly transform your patient outcomes?